So today's lecture is going to be on primary prevention of cardiovascular disease. And what we mean by that is how can we prevent cardiovascular events before they happen? So you do have secondary prevention as well, where you would, someone say have a heart attack and you want to prevent a second heart attack. So we have secondary prevention when someone have like a heart attack or a stroke and you want to prevent a second event. So that's a secondary prevention. We're talking about primary prevention. We want to prevent the patient from having the first event. Okay. Now, what we're going to discuss is the most current guidelines. That's the American College of Cardiology, the American Heart Association 2019 guidelines. And so essentially, we're looking at how to prevent atherosclerotic cardiovascular disease or vascular disease, heart failure, and atrial fibrillation as well. So what they're recommending is a team-based approach. In former years, we'll take this on all by ourselves, and one doctor would try and do everything. They're discouraging that. So it should be a team-based approach, and you have to incorporate the patient in all of this, and you have to use all the other specialists that are available. You need to use the dietitian, you need to use the psychiatrist or psychologist, you need to pulmonologist, whatever specialists that can help the patient, you need to incorporate them in the care of the patient. Now, the guidelines basically just look at adults from age 40 to 75 years of age. We'll talk a little bit about younger patients, but the guideline is specifically for adults between 40 and 75 years of age. And it looks at a 10-year atherosclerotic cardiovascular disease risk estimation. So essentially what we mean by that is you want to do some sort of risk estimation for patients over 10-year period, see what is their risk of developing some type of atherosclerotic cardiovascular disease. Is it 0%? Is it 5%? Is it 10%? Is it 20%? Is it 30%? So we have what we call a pooled cohort equation that we can use to give a patient a risk estimation, and we'll look at that. So we call it the pool cohort equation. The good thing about it, 20 years ago, we have the equation, we print it out and we put in the numbers and we had to calculate the risk ourselves. They've made it a little bit more easier. So you can Google it, pull it up, and that's what I've been doing. Just pull it up and just drop in the numbers, and you get a risk estimation pops up. So what I encourage you guys to do is, especially the physicians, is to just Google pool cohort equation and just put in the numbers, and I'm going to show you what data you need to put in order to get a risk estimation. And this should be a clinician-patient risk discussion. So it's not a situation where you sit back and you tell the patient, then you have to do X, Y, and Z. It is a little bit more involved, and we're going to go into all what you need to do. I mean, you before you start talking about risk reduction, you need to know a little bit about the patient. You need to know the patient environment, financial situation, you know, family environment as well. So they're recommending a little bit more involved approach to risk reduction. Um, so the risk estimation uses a number of data. And one of the things that we look at, or they look at, is especially before you start in any type of drug for like hypertension, for dyslipidemia or aspirin, you should put your patient in the pool cohort equation. When we did hypertension, you know, we went over that and we said that before you start treating your patients with drugs, you need to see their risk. Are they low risk? Because if they're low risk, you might be able to satisfy with a blood pressure of, say, 130 over 80. If they're high risk, then you might want to reduce the pressure a little bit more than that. So we went over that. And then similarly, if you're considering drug therapy for cholesterol, you should do the pool cohort equation and determine the patient risk and see if they would benefit from statins. Aspirin has been in the news lately because we have to take a lot of patients off aspirin because if they don't satisfy the risk to start aspirin, then it should not be an aspirin. So if you consider putting the patient on aspirin, you have to put them in this pool cohort equation. You have to put them in that and see if they would benefit from aspirin. Okay? Plus 1404-736-1880. Okay. So let's look at plus 1404-736-1880. So let's so you may have to use, and we'll go over that again, you may have to use other risk enhancing factors, and one of them is the coronary artery calcium scoring. So especially if the patient is borderline or intermediate risk, you may have to use the coronary artery calcium scoring to see if they would benefit or would benefit from statins, especially. All right, so this is the pool cohort equation. The good thing, you don't have to memorize it, you just have to Google it. For people doing exams, I don't think they're going to they'll probably ask you a little bit about it, but you don't have to memorize it. So the things that you're going to plug in, so when you Google it, the good thing about it just show you one thing. So you put in the patient age. So it has a section for age, and you just put in the patient age, current age. Then then the next thing. So it automatically moves to the next data set, and then it's asking for the patient's sex. You put that in. Then it automatically moves to the next data set, and then it asks for race. So it has white, African, American, and other. And then systolic blood pressure. So you have to measure patient's systolic blood pressure. You don't need a diastolic blood pressure, but usually when you do blood pressure, you get systolic, diastolic. But in this pool cohort equation, says a L supposed to be there. You need just a systolic blood pressure. You need total cholesterol, so you need to get a lipid profile. You need the HDL cholesterol. You don't need the LDL cholesterol, but the HDL cholesterol. Then whether or not the patient is diabetic. And so yes or no. And you need to know, is the patient a smoker? Okay. And yeah, you put that information in. Then the next data that you need is the patient hypertensive? And if the patient is hypertensive, are they on treatment? So if they're hypertensive and on treatment, you put yes. If they're hypertensive and not on treatment, you put no. You don't need, these are other stuff that's there, but you don't need that to do the risk calculation. Okay? So once you plug in these information, then a percentage risk will come up. So I'll recommend you guys Google it at some point in time and then just put in some numbers and get accustomed to using it. So what it's going to give you is the 10-year risk of a first cardiovascular event. Okay, whether it's 0%, 5%, 7.5%, or greater than 20%. So it's going to predict that 10-year risk of first cardiovascular event. And when we talk about cardiovascular event, we talk about strokes or heart attack. Okay? Now, the higher the absolute risk, so say someone with a risk of say greater than 20%, the greater the benefit of therapy. So patients with the highest risk, they benefit more from treatment. Okay, so we have been discussing certain guidelines for our cardiovascular disease, and we talked about healthy diet, and we've been pushing the Mediterranean and DASH diet. So a healthy diet should include, so these are some of the things you're going to do to prevent primary, or even if it's a secondary prevention, but we're talking about primary prevention today. So healthy diet is important for primary prevention of cardiovascular disease. Lots of vegetables, fruits, nuts, whole grain, lean vegetables or animal protein or lean animal protein, and fish. Okay, so these are some of the healthy diets that is recommended for primary prevention. And you should minimize the intake of trans fat, red meat. Okay, so especially processed red meat, the bacon and the sausage and stuff like that. Also, refined carbohydrates, reduce refined carbohydrates, and sweetened beverages. Overweight and obese individuals should be counseled, and you should recommend caloric restriction for them as well. And then we also push exercise. And then when we talk about exercise, we have moderate exercise. So moderate intensity physical activity or exercise is defined as, someone doing a brisk walk or something of that sort. So you need to do about 150 minutes per week, cumulated that is. So if you're going to do moderate intensity physical activity, which is like a brisk walk, so for the week, all you need is 150 minutes. If you're going to do vigorous intensity physical activity, which is like a jog or, those of you who cycling as well, you need 75 cumulative minutes for the week. Okay, so moderate intensity exercise, 150 minutes per week. If you're going to do vigorous intensity physical activity in 75 minutes. Now, patients with diabetes mellitus, they have to adopt a lifestyle. They have to adopt lifestyle changes, and that go, dietary habits. They have to follow strict dietary habits, and the exercise that we just mentioned. Moderate physical activity or vigorous physical activity. Now, if you have diabetic patients and you want to prevent cardiovascular disease, they recommend that you start metformin. Metformin should be a first-line therapy. Okay, so all your diabetic patients should be on metformin unless unless there's a contraindication. Okay. There are a few new diabetic medicine, sodium glucose co-transporter 2 inhibitor, or a glucagon-like peptide 1 receptor antagonist. So if the patient, in addition to the metformin, if they have other risk factors for cardiovascular disease, then they should be on these two medicines. So, these medicines have been advertised quite a bit. So that is the stepwise approach for your diabetic patients. What about smoking? So you're going to assess for tobacco use. That's one of the things that you need to push for primary prevention, smoking cessation program. Advise the patient to quit, and then aspirin, as we mentioned before, we don't routinely use aspirin anymore. You have to put the patient in the pool cohort equation, and if they satisfy the risk profile, then you put them on aspirin. Okay? So again, you use aspirin infrequently in routine primary prevention of atherosclerotic cardiovascular disease. So 10 years ago, everybody, we used to put them on an aspirin, but the studies have shown that only the high risk individual need to be on aspirin. Okay, statin therapy, just give me 1 second. Okay, so statin, so the pool cohort equation is very, well, the patient should be put in this equation to determine if they should be treated with statins. However, there are a few situations where you don't need the pool cohort equation. If the patient comes to you with a LDL cholesterol, that's a low density lipoprotein cholesterol greater than or equal to 190 milligram per deciliter, then you don't need anything else. This patient should be on statin therapy. If the patient is diabetic and is between the ages of 40 and 75, you don't need anything else. They should be on a statin therapy. Okay? However, it should be a patient clinician discussion. So you have to discuss with the patient the risk and benefits. So that is why you need to pull out your pool cohort equation, and you need to say, well, this is your risk of developing a heart attack in 10 years. If it's greater than 20%, if it's 30%, you need to tell the patient that, your chance of getting a heart attack is more than 30%. And patients will follow that. So you need to be familiar with the equation and use it. All right. We discuss hypertension in details in the guidelines. When you're going to treat hypertension for primary prevention or even secondary prevention, the non-pharmacological intervention, your diet, your exercise, smoking cessation, those type of things, you need to go first. And if you remember what we talk about, try and get that blood pressure less than 130/80. Okay. When we look at atherosclerotic cardiovascular disease, in the United States, is a leading cause of death and illness. So cardiovascular disease is and globally as well. So not only the United States, but globally, it's the leading cause of morbidity and mortality. More than 200 billion is spent annually to treat cardiovascular disease. And we use that in healthcare, medication, loss of productivity. Those are some of the areas that we spend money on. So the ideal cardiovascular health factors have been associated with lower prevalence and incidence of. So if you're gonna follow a healthy or a ideal cardiovascular health, then it's going to reduce heart failure, atrial fibrillation, cancer, depression, and cognitive impairment. So it's not only, you know, uh, atherosclerotic cardiovascular disease that you're going to lower the prevalence and incidence, but other spin-off conditions. So a healthy or ideal cardiovascular health is important. So prevention strategies must include lifestyle optimization. So, you know, you have to look at the whole person. Just give me 1 second. Okay. So, preventive strategies must include lifestyle optimization. So improvement in diet. So you have all your patients who come to you and you're thinking about primary prevention, you have to discuss diet, okay? You have to discuss physical activity. And then if the patients smoke, the avoidance of tobacco use, and secondhand smoke exposure as well. So the patient may not smoke, but they may live in an environment with someone who smokes, so you have to discuss that. It should be a patient-centered approach. You have to know a little bit about your patient before you start, you know, treating them. So again, as I say, you have to know the patient's socioeconomic status, you know, have an idea where they live. Are they living at home with their family, or they're in a group home? You know, so you have to have an understanding of your patient, and then you do your estimated risk of a future atherosclerotic cardiovascular disease. So you're going to use your pool cohort equation. Again, all you need to do is just Google it and put the information in, and you'll get a risk. A risk will pop up. All right. So we're going to look at the recommendations, and then we're going to look at the class. So it is a class 1 recommendation, okay? So this is the recommendation for a patient-centered approach to comprehensive atherosclerotic cardiovascular disease prevention. So it is a class 1 indication, so it should be a team-based care approach. It is recommended for control of risk factors. Again, we said it should be whichever primary physician or cardiologist. You need to get nutrition involved. You might have to get a psychologist, psychiatrist, or whatever else involved. So it's a team-based approach. And to be honest with you, most treatment in medicine today is recommended that it's a team-based approach. And especially in a lot of stuff that we do in cardiovascular disease treatment. You know, we're doing a stent today. It should be a team-based approach as well. You know, you should involve the cardiothoracic surgeon along with the interventionalists and stuff like that. So you're going to discuss the best approach for the patient. All right, so class 1 indication again, so it should be a shared decision making. It should guide the discussion about the best strategy to reduce the atherosclerotic cardiovascular disease risk. And then class 1 again, social determinants of health should inform optimal implementation of treatment recommendation for the prevention of atherosclerotic cardiovascular disease. So again, as we said, it should be a team-based approach, multidisciplinary health profession, and again, clinical decision making should be based on, the patient socioeconomic status, education as well. Okay. So collaboration among the different clinicians, the patient and the family in some situation. And what it has been found is that this approach results in significant improvement in patient outcome. So the team-based approach um, it does result in improvement in the patient outcome. So again, as we say, socioeconomic inequalities exist. So you can't have one prescription to fit all your patients. You know, some patients need a little bit more assistance. They're going to be non-compliant. They're not going to, you know, take the medicine because they might not be able to afford the medicine. So if you're a facility that gets samples, you may have to give the patient samples, or you may have to mobilize the social service to help out. You have to look at the educational level of the patient. You know, some patient may not understand what you're saying. So you might have to use a different approach. And then again, cultural influence. If you practice, even if you practice in a single culture environment, uh, you know, different areas may have different uh, cultural practices. So you have to be aware of that. And then in the United States, it's a nightmare because you have so many different groups. You have to know about the patient work environment and also the home environment. So you have to know about the patient. The Centers for Medicare and Medicaid, that is the major payers in the United States, found that there were 5 domains of non-health related measures that affect health outcomes. And those were housing instability. You know, the patient is homeless, then I mean, maybe non-compliant because they don't have a fixed address. Food insecurity was another one. Transportation difficulties, utility assistance needs. If a patient have no electricity, they don't have a refrigerator at work, where they're going to put their insulin and stuff like that. So interpersonal safety as well. So these are the 5 domains that the Centers for Medicare and Medicaid found to affect health outcomes. So, all right. So when we talk about social determinants of health, um, you know, the adults should be routinely assessed for psychosocial stressors. So again, you have to know what's going on with your patient. And if they need counseling, then you should be able to send them to a professional who can help them in that area. Health literacy should also be assessed because patient may not understand anything you're saying. I mean, you might have a beautiful dissertation and patient understand exactly nothing that you have said. So you have to be aware of the patient that you're trying to treat. So in addition to the prescription of diet modification, body size perception, as well as social and cultural influence, all these things should be assessed. So the potential barriers to adhering to a heart healthy diet should also be assessed. Why is the patient not following your advice, including food access and economic factors. So again, you have to be aware of your patient and you have to get involved. So the guidelines are saying that you really have to know your patient. You cannot treat a patient by knowing the patient superficially. The outcome is not going to be as good. And then we talk about exercise. So if the patient cannot do moderate or vigorous physical activity, they should encourage them to do something. Okay. So obesity and weight loss. So lifestyle counseling for weight loss should include assessment and interventional recommendation for psychosocial stresses, sleep hygiene, and other individual barriers. Weight maintenance should be prompted in patients. So you should always try and discuss weight, obesity, because it's one of the significant risk factors for atherosclerotic cardiovascular disease. So you have to go over a healthy lifestyle, which is diet and exercise. So our diabetic patients is a unique group. So in addition to the prescription of type 2 diabetes, as intervention, environmental and psychosocial factors, including depression, stress, uh, and social support. So your diabetic patient, you really have to get involved with them. And then blood pressure, you have to, is the patient having adequate amount of sleep? Because if they're not having sufficient sleep, that can result in elevated blood pressure, or the quality of the sleep may be abnormal. So they may be lying in bed for 10 hours, but they're not having quality sleep. So remember, sleep and obstructive sleep apnea can also elevate the blood pressure. So, and then the diet, are they on a low sodium diet? Are they drinking a lot of alcohol, stuff like that? And then we talk about tobacco treatment. So you really have to try for them to quit smoking. So the regular risk factors for atherosclerotic cardiovascular disease is your diabetes, your hypertension, dyslipidemia, smoking, and family history. So these are the traditional risk factors. But there are some other what we call risk enhancers, and we'll discuss those a little bit later. So the recommendation for assessment of cardiovascular risk, who are you going to use your pool cohort equation on? Which individuals? So the recommendation is that it's a class 1 recommendation. Any adults between 40 and 75 years of age, the clinician should routinely assess traditional cardiovascular risk factors and calculate the 10-year risk of atherosclerotic cardiovascular disease by using the pool cohort equation. So the current guidelines recommends that individual between 40 and 75 should they should have this pool cohort equation applied. So just put in the numbers and you will get the risk. So in order to prevent, to do primary prevention of atherosclerotic cardiovascular disease, you have to do the risk. Because you cannot prevent something and you don't know the burden. So you have to assess the risk, okay? And when you do the risk, it will help you in decision making. It guide you in decision making. How you're going to treat this patient. Okay? Are you going to use statins for lipid management, or are you not going to use statin? Are you going to use blood pressure medicine for the patient hypertension? And then other risk reducing strategies. But you have to do that risk estimation first by using the equation. Okay, so for adults 40 to 75 years, the 10-year atherosclerotic cardiovascular risk, you're going to do it for you can do it for the different race and sex, as we showed you the different data. So if the patient have stage 1 hypertension, if you remember, stage 1 hypertension is when you have a systolic blood pressure between 130 and 139, diastolic 80 89, that's stage 1. If they have a less than 10% risk, then this, you can settle with a 130 over 80. But if they have a greater than 10% risk of cardiovascular events in 10 years, then you probably should treat them to the blood pressure less than 130 over 80. And then similarly, when we talk about cholesterol, so when someone aged 40 to 75 years of age, the patient comes in, and you're going to put them in that risk calculator. And if that comes out to be less than 5%, then we say that they're low risk. And these individuals, um, we probably wouldn't treat them with cholesterol medicine. So if they are low risk, we can treat them cholesterol medicine. If they're borderline risk, so a risk of 5 to 7.5%, so this is a borderline risk. It's a little bit more difficult, and especially your intermediate risk, which is 7.5 to less than 20%. So this is the intermediate risk. So your borderline and your intermediate risk, you need a little bit more information in order to treat them with your cholesterol medicine. For high-risk individual, greater than 20%, there's straightforward. You're going to treat these patients. You're going to treat them with cholesterol medicine. Low risk, no treatment. For your borderline and your intermediate risk, you need a little bit more information before you start treating them. All right. There's some situation that you wouldn't use the risk calculator. If the patient has a familial hypercholesterolemia, you don't need it because they have a family history of high cholesterol. So you go ahead and treat them. You don't need to put them in the risk calculator. But as we mentioned before, if they have borderline or intermediate risk, so borderline is your 5 to 7%. So again, you put them in the risk calculator, and the risk, it will show you, the risk might be 7%, so that will be borderline, or it may come out to be 10%, which is intermediate. So if you have patients in this group, you're going to consider additional individual risk enhancing clinical factors. So your borderline and your intermediate group, you're going to look at risk enhancing clinical factors. And these are some of the risk enhancing clinical factors. So these are relatively new in the guidelines. So family history of premature atherosclerotic cardiovascular disease. So your male patient less than 55, female less than 65. And then chronic inflammatory disease, rheumatoid arthritis, lupus, HIV. That's all. So these are some of the risk enhancing factors. So if your patient again is borderline or intermediate and they have these risk enhancing factors, that will prompt you to treat them. So again, family history of premature atherosclerotic cardiovascular disease, chronic inflammatory disease such as your rheumatoid, your SLE, HIV positivity, South Asian ancestry, South Asian ancestry, history of preeclampsia or preterm delivery. This is now a risk enhancing factor. So if the lady had a history of preeclampsia or preterm delivery, early menopause, erectile dysfunction, chronic kidney disease, metabolic syndrome, and persistently elevated inflammatory markers. So these are risk enhancing factors that would prompt one to treat your borderline or your intermediate risk group. So as we said, when we say family history of premature atherosclerotic cardiovascular disease, so male, if it's a male, less than 55, female, less than 60, and if the patient have primary hypercholesterolemia, there's some metabolic syndrome, which is a risk enhancing factor. So if you remember what we said metabolic syndrome is, elevated triglycerides greater than 150, elevated blood pressure, elevated glucose, a low HDL, 40 in men, less than 50 in women. So all you need is 3 of these factors, and that gives you a metabolic syndrome. So a tally of 3 makes the diagnosis. So again, for metabolic syndrome, your increased weight circumference, elevated triglycerides, elevated blood pressure, elevated glucose, and a low HDL. So all you need is 3 of these to make the diagnosis of metabolic syndrome. Chronic kidney. So these are risk enhancing factors. It elevates, if you have, you do your pool Current equation and you come out to be borderline or intermediate. If you have any of these, then it increases your chance of having cardiovascular disease, chronic kidney disease, with or without albuminuria, chronic inflammatory condition, rheumatoid, lupus, HIV, AIDS, history of premature menopause before the age of 40, history of pregnancy-associated condition, such as preeclampsia. And then we talk about the high risk, race and ethnicity, Southeast Asian ancestry. High triglycerides, that is greater than or equal to 175, okay? And then the elevated high sensitivity C-reactive protein. So you would only do your C-reactive protein if it's a borderline or intermediate risk individual. And a significant high sensitivity C-reactive protein is greater than or equal to 2 milligram per deciliter. All right, so, okay, so in the guidelines as well is, risk enhancing factor, elevated lipoprotein little a. So lipoprotein little a greater than 50, greater than or equal to 50 is significant. For those of you who use nanomoles per liter, it is greater than or equal to 125. And then, so lipoprotein little a. So this is a risk enhancing factor. You probably won't routinely do your lipoprotein little a. ApoB, which is another lipid factor. So your ApoB greater than or equal to 130 milligram per deciliter. You would do that only if your triglyceride is greater than or equal to 200. And then another risk enhancing factor is your ankle-brachial index of less than 0.9. So again, you're only going to look at these things if the patient is borderline or intermediate risk when you put them in the pool Cohort equation. Okay, low risk patient you don't treat. High risk patient you're definitely going to treat. It's just that borderline and intermediate group that you need some clarity on. Okay, so we're going to stop here. It's a lot to digest, but those are the current guidelines, and